Welcome back to Reimbursement Readiness, Business Tips for Wound Practice. We are honored that you decided to spend a few minutes of your valuable time to learn about the 2026 Home Health and Durable Medical Equipment Supplier Final Rule, which goes into effect in January of 2026. And a special welcome to my third reimbursement friend, Yesenia Banks, who will explain that final rule. Now, by the end of Yesenia's episode, you should understand how home health agencies receive increased payment when caring for patients with wounds and ulcers, and how the home health agencies are not responsible for purchasing negative pressure wound therapy, durable medical equipment, and supplies, but how the home health agencies are expected to bill the Medicare program separately for disposable negative pressure wound therapy pumps. Yesenia, welcome, and we are ready to learn from you.
Well, thank you. First, I want to thank all of our wound care providers for everything that you do. I know that it can be a challenge at times, so I thank you for being there to help our patients heal. So, before we get started, I want to review with you the model on how home health agencies are paid. So, as if things were not enough of a challenge in 2020, we think back 5 years ago, January 1st, 2020, CMS replaced the older home health payment system to shift payments from volume of service to patient-driven clinical needs using a 30-day period. The purpose of this change was to improve payment accuracy by basing reimbursement on patient characteristics such as diagnosis, functional needs, comorbidities, rather than the number of therapy visits. The end goal was to create a more value-based system, and that is when they shifted over to the Patient-Driven Grouping Model, better known as PDGM. Now, PDGM is made up of several different factors. It uses 30-day periods as a basis for payment. I want to show you the diagram that provides an overview of how 30-day payments are categorized in the different case mix groups. There are 432 case mix groups that are calculated and create this payment basis and the number of visits required. I'm going to go through each of the different criterias that is determined that will at the end create the payment. First is the admission source and the timing that is determined. When a patient is either referred by a physician, a primary care provider, or being discharged from a hospital or skilled nursing facility, that is what is determined by the admission source. So the admission source is determined based on the healthcare setting that was utilized 14 days prior to the home health admission. Now, when you look at the timing component, the first 30 days is considered early, and then any subsequent 30 days will be considered late. So you first have your admission source. Where is the patient being referred by? Is it the primary care doctor, or is a patient being discharged by from the hospital or SNF? Then there is a timing, and there is either late or early or late. Then you look at clinical groupings. You'll notice that there are 12 available clinical groupings that are based on the patient's primary diagnosis. You'll also notice that one of the clinical groupings is wounds. So, based on the primary diagnosis, the clinical grouping is determined. Now, next is the functional impairment level. There is low, medium, and high. This is based on the assessment that is done by the home health agency, and this is where information such as, can the patient bathe on their own? Can they feed themselves? Can they clothe themselves? Are they at risk at falling? Once that assessment is complete, the functional impairment level is determined, whether it's low, medium, or high. Next, you have your comorbidity adjustment. Now, this is an opportunity for the home health agency to list all other secondary diagnoses that are reported on the claims and have a substantial impact on the possible reimbursement from Medicare. You have none, low, or high. It's very important, and I remember when PDGM was first rolled out, that Medicare made it a point to say that accurate and valid diagnosis had to be listed on the claim form. So diagnosis codes, as we all know, are very specific, and so unspecified diagnosis codes are not accepted. It is very important for the home health agency to list accurate diagnosis codes. So once a home health agency determines the admission source, the timing, the clinical grouping, which is where the principal diagnosis is the principal diagnosis, the functional impairment level, low, medium, or high, and the comorbidity adjustment, a HERG score, which is Home Health Resource Group, is determined. There are over 432 clinical groupings that are determined by this assessment that will determine the weight that will be calculated by the base rate that is set each year, and then the number of visits that are required to get the 30-day payment. Now, one thing I want to make sure that I mention is payments for 30-day periods where the number of visits have not been met fall into what is called a LUPA, low utilization payment adjustment. And that is when the home health agency is paid by visit versus the 30-day full payment. There are other outlier payments that are available if a patient requires an unusually large number of costly visits that is available to the home health agency. There is also information on the CMS website that explains how payments are calculated if the patient has a gap in home health coverage, if the patient has returned to the hospital, and all of those other scenarios are available on the CMS website. My goal today with you is to provide a high-level overview of how the patient-driven grouping model, the PDGM payment, is calculated, and then to talk to you about the 2026 rates. So, now that we've talked about the high-level overview, and I know some of you may be driving in a car or maybe wrapping last-minute gifts, let's dive into the 2026 updates. Now, there are several components that made up what that final home health rate is, and that rate was an overall decrease of 1.3%. And although a decrease is never good for providers in general, it is a smaller payment cut than what was originally proposed. Originally, it was an upwards of about a 6% cut. Just to know, CMS has made cuts to the home health providers in the last 3 years. So just want to make sure we're talking to the wound care provider that wound clinical grouping, out of the 432 groupings, all of the clinical groupings that are related to wound care are the highest paid clinical groupings. So that is important to know. And then one of the other points that I wanted to make is the average number of visits for a home health agency to receive the 30-day payment when they are seeing a wound care patient is 4. So it is the goal of a home health agency to strategize. Their largest cost is the labor cost, how much they're paying the nurses, their benefits, mileage, gas, all of those, the supplies that are included in that 30-day payment rate, which is also important to remember. So when they get that 30-day payment rate, it includes everything that they provide to that patient. The only thing, and I'll talk about that in a moment, is excluding durable medical equipment, negative pressure wound therapy, and disposable negative pressure wound therapy. So the goal of the home health agency is to make sure that they're strategizing, that they're seeing the patient, first of all, the required number of visits, but they also have to make sure that they're aware that unless it's an outlier payment, that they have a plan in place to make sure that the patient's needs are met, especially considering that they have had a decrease in payment for the last couple of years. So let's now go into the exclusions. And before we get into that, there is a slide that is available to you that shows you the clinical groupings. And you'll see on that slide the HIPS, the HERC score, the clinical group and functional level, the admission source and timing, the comorbidity adjustments, the recalibrated weight that is going to be multiplied by the base rate, and then the LUPA visit threshold. And again, it's important for a home health agency to make sure that they're seeing the patient the required number of times so that they can get that full 30-day payment rate rather than getting a payment per visit, which is quite a much lower payment rate. So now that we've talked about how they're paid, the PDGM model, and the updates for this year, let's go into the exclusions of that payment. And one of them is DME, negative pressure wound therapy. So when a provider, a qualified health professional, recommends and feels that the patient would benefit from durable medical equipment, negative pressure wound therapy, an order is sent to the DME supplier. The DME supplier then verifies the patient's insurance, benefits, goes through that process, notifies the patient of any out-of-pocket cost, and when all of that process is complete, the device and the supplies are sent to the patient's home. When the home health agency sees a patient at home, they are able to use the supplies, and there is no supply cost that is taken from that home health 30-day payment, since the DME supplier is able to bill the insurance company directly. This is one of the exclusions from that 30-day PDGM payment. Another exclusion is through the Better Wound Care at Home Act. Home health agencies are able to bill separately on the same claim form. They're able to bill on a separate line item when they provide disposable negative pressure wound therapy to a patient. There are times when the qualified health professional recommends durable medical equipment, negative pressure wound therapy, and the patient may not qualify or the wound has gotten smaller. So another option is disposable negative pressure wound therapy. And again, the home health agency gets that separate payment rate. It's become easier to bill, and they are able to bill on a claim form. One of the resources that will be available to you at the end of this presentation is a Medicare Learning Matters document that goes into detail about billing for disposable negative pressure wound therapy. Now, there were other updates in the home health final rule that I want to share with you that were that we were all anticipating and wanting more information on. CMS released the durable medical equipment, prosthetics, orthotics, and supplies home health final rule with provisions to restart the competitive bidding program. There is a lot of information on that new program, as well as timelines that will be available in your resources. Changes to the program is calculating the winning bid from the clearing price to 75th percentile of the winning bids. It requires significantly less financial documentation in the bid submission process. There have been additional product categories that have been added to the competitive bidding program. Continuous glucose monitoring and insulin pumps, urological, ostomy, and tracheotomy supplies have been added to the program. One other change is the increased frequency of surveys and accreditations. They are now required to, DME post suppliers will be surveyed and reaccredited at least every 12 months. So this is a change. Now, there is more information, as I mentioned, that is listed on the CMS website on the competitive bidding program, including the timeline and how they're anticipating when this will officially be rolled out. So more to come on that. But for now, I want to thank you for your time today. I know that this is a busy time for all of us, and I want to wish you a wonderful, safe, and prosperous new year. Again, the resources are available to you at the end of this presentation. Thank you for your time.